Please feel free to ask questions. We can go ahead and do that as the show progresses. It's a review of a lot of the stuff we covered last time, but there were difficulties getting that recording out, so I apologize for that. We're just going to start with the overview. I'm sure by now everyone kind of follows this every 10 minutes to see what's going on in the world. But this is the Johns Hopkins site. It kind of gives the coronavirus like dashboard for the world. As of last night when I did this, there were 2,600,000 confirmed cases, with a huge proportion being in the United States, actually, more than Spain, Italy, France, Germany, and the United Kingdom combined. And a lot of that is located at major metropolitan centers. The death toll worldwide around 183,000, and then in the United States, that death toll now is around 50,000, just under 50,000. How that look? This is a heat map for the United States, and it's by population density. So places in North Dakota, some places show up brighter because their population density is low in proportion to their number of cases. You can see the graph in the bottom right-hand corner, and that's kind of the confirmed cases, per day, or not per day, but total, as it's kind of progression. That's a exponential curve. They think it's starting to flatten out, really. And the important thing to know with that, you'll hear people saying that the number of cases per day is stabilized. What that typically means in epidemiology is that curve is about halfway to the top. So where that exponential curve goes up and then starts to flatten out is about halfway to the top. So let's see what that means kind of United States wise. It's unclear how any of the relaxation and social distancing, as well as the changes that are occurring, are going to affect that. For Montana, we have a much lower population density. Again, the models that they use to predict these things are really based on fixed rates of transmission, and they're much less accurate as far as low population density areas where we are. Missoula is now up to 39 cases. It's actually slightly higher because there are some patients who had known exposures with diagnostic x-rays that did not get tested. So that number is actually in the 40s, but it's reported as lower because this reflects test results. There are hot spots based on kind of local factors in Gallatin County and Billings. Billings now is seeing more cases. The state testing capabilities have gone up quite a bit. The state is now, not running their testing at capacity right now, so there's room to be doing more testing, and they have expanded capabilities, and they're testing 7 days a week. It's still limited by travel, and those turnarounds are 24 to 48 hours. But we'll see there's not, the graph in the bottom right-hand corner represents our cases per day. And initially there was, kind of a surge there that it's kind of dropped off. But again, this cases per day in a low population density area is going to maybe not reflect our true burden of disease. That's probably not the peak that we're going to see. So this is United States data based on the modeling. So there's the actual is the red line, where the predicted, ranges quite a bit. The deaths per day, they're looking at somewhere about, 2,500 deaths per day. And it started to kind of come down a little bit. And again, you can see the error bars on this are pretty dramatic. So that's more than doubling the number of deaths per day, depending on what happens. And then that taper ends in July or June, where it starts to taper off. I don't know that that's what this is going to look like. I think we're going to continue to have little spikes in this with relaxation of social distancing, as well as, again, this getting into specific areas where there's higher population density. This may change a lot and kind of reflect these kind of peaks and valleys that you can see there. This is hospital resource use. So again, the prediction is that we could have a big surge still. They're saying that it was 6 days since their predicted peak. resources, as of April 17th, they had a bed shortage of 2,300 beds with an ICU bed shortage of 8,000 beds. So that's still pretty significant. You can see the invasive ventilators projected there as well. Almost 20,000 ventilators with a shortage there of quite a few ventilators. So,
Mike, has anybody died that you know that needed a ventilator that didn't get one? Has that happened?
Well, they've had to move people to alternate ventilator devices where they used like a closed loop BiPAP machine. And they have actually triaged people to no ventilator care in New York. So New York has a statewide pandemic ventilator triage thing that they had in place before this, based on the experience from SARS. And so they, if people meet too many risk factors, they are too sick, they may decide not to put them on a ventilator. So this is the deaths. Again, this is COVID deaths here in the United States. Total deaths of 67,000 projected by August 4th. Again, I don't know what this will look like, but it can kind of show you how wide the error bars are. So here's the Montana specific stuff, and this kind of shows some of the limitations of this modeling. If you looked at this back in the beginning of April, there was this smooth curve that showed kind of our deaths per day getting to a peak and then dropping off. But because our low population density, I don't think that's going to happen. I think we're going to have these little mini surges of patients. Hopefully that doesn't become overwhelming, and that's kind of the goal of social distancing and the other community health interventions we're doing. So I think this will continue to look like this. We'll get little spikes and then it'll drop off. And so hospital resource use is still low. So there's no ICU bed shortage or ventilator shortage in Montana. Again, because the cases are so sporadic and they're spread out right now. So total deaths in Montana, 18 COVID deaths. And it's kind of this like stepwise plateau, which is what I think we'll see. I think we'll see some deaths and they'll level off, and then we'll get more, and then it'll kind of level off again, barring any drastic changes in community transmission. So I still get a lot of questions about, isn't this just the flu? And that's a really bad analogy for a couple of reasons. One is we have a flu vaccination every year, and the flu season is long, from September through June. And so those flu deaths that are occurring every year are occurring over a long period of time. We have a 60% vaccination rate nationally, so it could probably even be lower than that, but we don't vaccinate as well as we could. And additionally, we have some treatments that are effective for the flu that may shorten the duration and severity of the symptoms, as well as a newer treatment now that may actually be even more beneficial. The compressed nature of how this is occurring is significant. So if we look at having a lot of influenza deaths in 1 year, they suspect for this flu season, 2019, 2020, there'll be somewhere around 40,000 deaths from influenza. That number could be as high as, I think they said 60,000 deaths from influenza. And again, that's over a ton of months. And that does count cases that are not confirmed. So that's, using epidemiologic data for, misses and then test results, false negatives. So that incorporates a lot of data. And that's, so that's over months. Whereas we look at what's happened between, March and, or just in April, looking at those deaths have already exceeded the influenza deaths so far this season in just 1 month. And the amount of resources that are required to treat the patients, significantly higher. So kind of a bad analogy. I found this slide, which I thought was helpful for illustrating this. If you looked at deaths per day in the United States back in March, at the beginning there, 16th to 22nd, 337 deaths per day. That didn't even get into the top 15 causes of death per week. So these are per week, I'm sorry, per week in the United States. Then you go March 23, so just 1 week later, Now we're in the middle of the 15 most common cause of deaths per week in the United States, slightly ahead of things like hypertension. 1 week later, it's now the third most common cause of deaths per week with 7,000 deaths per week. I keep misspeaking this, I'm sorry. These are weekly data, but it's deaths per day, I'm sorry. So deaths per day. So, and then it dramatically increased, now it's second only to cardiovascular disease. So if you look at cardiovascular disease, you get 12,000 deaths per day in the United States. COVID is now just slightly less. So that's a dramatic increase in what's killing people per day in the country. And that's not the same as influenza. So very, very different, very compressed timeline, a lot more resources used. I've also heard people say that, well, it's like SARS, that it's going to go away soon. Well, SARS happened in 2003. There were around 800 deaths worldwide, and it was confined to about 20 countries. So this is now in almost every country, and with tremendously more deaths, and doesn't look like it's going to go away in 1 month, which is really what happened, or over several months with SARS. So the original SARS virus. So what is this again? So SARS-CoV-2 or COVID-19 illness is a coronavirus. It's got a small genome. It doesn't require super accurate replication, so it tends to develop a lot of mutations. There are lots of other coronaviruses again. Some of those are the common cold. SARS-CoV-19 is not called that because there are 19 other coronaviruses. It's called that because it happened in 2019 in China. And some of these are very mild illnesses like the common cold, where others like SARS-CoV-1 and MERS, the Middle Eastern Respiratory Syndrome, were very severe. They weren't transmitted quite as easily as this was, though. This thing binds the ACE2 receptor, which is in the lung and the GI tract, and as well as some other places. And that may be a target for treating it, but that's just kind of how the virus attaches to the cells to spread. So, it's primarily spread by large droplets. Those are, greater than 5 microns. So your, N95 masks are down to 3 microns. So for large droplets, that's more than adequate. And actually, N95 masks will trap significantly smaller particles down to a couple microns as well because of how they work. Surgical face masks will stop all these things around 5 microns as well. The definition for close contact for the CDC is really being within 6 feet for longer than 10 minutes, and that's kind of based on where they measured droplets that fall out of the air in people who are coughing, and most of them did not go farther than that 6 feet. So that's a pretty safe distance. That's why we're starting our evaluations at 6 feet. And then contact with things that those droplets settle on is another big source for spreading of this infection. That's why not touching your face is so important, and good hand hygiene. Probably the most common method for transmission is actually touching something and then contaminating your mucous membranes. So there's a lot of discussion about aerosolization, and aerosolization does occur with this, but looking at tons of data, they have not specifically documented that this is transmitted by aerosolization. There is probably some transmission in these aerosol generating procedures, but outside of that, it looks really low. Where this idea came from was looking at the original SARS virus, and they had some providers who developed the SARS illness after things like CPR and nebulization, and those were the only things they could identify that may have led to their exposure. So that's where the aerosolization comes in. I think we should be using N95 masks for sure for anything aerosolized. And I think that now that our supply chain is kind of improved, we should transition to using surgical face masks for all encounters, and then using N95s for known exposures or known patients, as well as patients who are likely. So that would be a change from what we're doing now, and it would be permitted based on whether we have the supplies available to do that. That's the current CDC recommendation. Now that most hospitals are catching up on the PPE, they're recommending doing that in certain care areas, like cohorted inpatient areas in the hospital, as well as the emergency room and potentially the operating room as well. So I think that's a reasonable change to make as long as we can sustain it. That being said, we should understand that the special, droplet and contact precautions that we're doing now are probably adequate. So, but I think that's a change that we should look at making now that we have the supplies. So, incubation and onset for this, the range they put is 2 to 14 days. Again, a lot of this is based on the SARS virus, not so much this acute, COVID-19 illness. The mean time to developing symptoms with COVID-19 is probably around 5 days. Most patients, when they're starting to develop worsening symptoms, they start getting short of breath around 6 days. They start seeking medical care or admission around 8 days, and ICU admission around 10 days. The clinical presentation, again, it can be just vague constitutional symptoms. There's a lot of people who are probably asymptomatic out there. Upper and lower respiratory symptoms. GI symptoms may be more common. Myalgia, fatigue, also common symptoms for this. So 50% are febrile at presentation. That gets up much higher once over the course of the illness, especially once patients are hospitalized, followed by cough and dyspnea are common. GI symptoms maybe 10 to 20%. So risk factors, again, age over 55, hypertension, cardiovascular disease, diabetes, underlying lung disease, and immune compromise. There is some actual question about people on some immunologic agents that they may actually be at lower risk for severe illness, but I think that's all conjecture at this point. So clinical course, this is looking at stuff from Everett and Swedish. They had a 25% mortality for patients who were hospitalized. If they ended up in the ICU, that mortality was around 66%. Some other centers are reporting a little bit lower. They're extubating about half of the patients in the ICU. The average age for survivors is younger, 49. Requiring the ICU, those patients average a slightly higher age, again at 63. And then the patients who expired, average age around 70. That you can see the age ranges on there too. So, some quite older people have survived this now. It's actually higher than this, but so like I think there was someone in their 90, like 98 or something, 99 who survived this now. So again, 911 is recommending droplet for fever, any respiratory symptoms, cough, shortness of breath, respiratory distress, and for any generalized illness. Travel's probably less important. I would still ask, but it's probably less important now. And I would still ask if they have contact with a known documented case.
Any place to travel to that we're particularly concerned with now?
Well, I think that any major metropolitan area, to be honest, is probably a risk factor. But certainly, areas like New York, Maryland, Florida. So we should be using the airborne precautions again with the N95 mask for sure for any arrest situation. And I would put in here that we need to communicate that this is a critically ill patient to the hospital as soon as possible, because we know how long it takes to put PPE on and organize the resuscitation room. And the sooner we get that out, so any cardiac arrest where you're going somewhere, you want to let the receiving facility know as soon as possible. Because that gives them time to adequately get respiratory therapy to the emergency room, to get the pharmacist ready, for providers to get their PPE on. So that communication point is super important. Having 911 alert you guys is important, and the same thing is important for the hospital, even if you don't have all the information for the patient. Again, beginning all assessments at 6 feet. We're getting pre-arrival instructions from 911, hopefully. Limit the number of exposed providers if possible. If someone's critically ill, we still need to do business as normal and not not wait too long to get into that patient. We need to use the appropriate level of PPE, but we should be, still trying to do a good job of, assessing patients quickly and providing life-saving interventions. So I think that, again, I just say that I think we'll look towards using N95s for known or suspected patients again, and that'll be a big change coming up. So look for that. Donning and doffing, if you don't review this once a day, that's probably a bad decision. You should kind of review this every day. I would suggest having a dofficer or someone who's assigned to make sure you're taking this off correctly, because that is really the most important risk, is when you're taking this stuff off is when you're most likely to contaminate yourself. Hygiene, don't touch your face. Hand washing, you can use 20 seconds with just soap and water is fine. Using the 60 or 70% hand wash as appropriate. The EOC has the hand wash that's pretty liquidy, but does work good. So clinical management, again, a lot of these patients don't require hospitalization. We want to be using our non-transport guideline if possible, minimizing exposed providers by staging fire if appropriate. Providing supplemental oxygen. So any wall source, nasal cannula or non-rebreather, does not generate aerosols. So those are relatively safe procedures. You can put that on the patient. I put in here allow recumbent positioning, so we can allow the patient to position themselves on their side, and we probably encourage that if we're having trouble maintaining their oxygen levels. That's been shown to change the ventilation perfusion relationships that are happening in the lungs, and may improve oxygenation. So you can have them shift positions every few minutes, or if they find a position where they're oxygenating better, allow that. Prone positioning might even be better, but we don't really have a feasible way to do that right now. You could maybe set that up with pillows, but it's difficult to put belts on someone then. So there's transportation risk with that. So avoid aggressive fluid resuscitation in these patients. They've really shown that too much fluids early leads to worsening pulmonary edema. So they really want to run these patients dry. In the intensive care unit, they're actually giving them diuretic medications if they're not having a slightly negative fluid balance. And then if they can't do that because of kidney function, they're putting people on continuous dialysis to take fluid off of them to keep them with a relatively low volume. Avoid steroids unless they have asthma or COPD. Like severe asthma, severe COPD, we should still use steroids because they're probably going to get benefit, but they have shown that there's probably some worse outcomes from patients who don't require steroids that are getting them. I would be using the MDI with the spacer. That does deliver albuterol just as well, using 4 to 6 puffs, up to 8 puffs actually, but you just have to make sure you're timing that right so the patient completely exhales before they take that breath in through the MDI. If we still need to use nebs, we need to do it. I would try not to do it in the back of the rig if you don't have any other option, but we don't want to be, again, denying things to patients. The same thing with CPAP. If you don't have any other option, you might have to do it. And just, you need to notify the receiving hospital. I would try doing repositioning and higher liter flows that I normally wouldn't do, but if you need to, that's still something.
Like, where's CPAP at in terms of how well it's working?
So there's varying thoughts. There are some people who are very wedded to the high flow nasal cannula. They're delivering like up to 60 liters per minute through a nasal cannula that's well sealed, that has a high fraction of inspired oxygen. That's from this trial called the Florali trial, where they found that with pneumonia, and patients with viral pneumonia in particular did well with that, and it may avoid intubation in some of those, or delay that till you can actually have a ventilator available. There's other people who've had good luck with well-fitting CPAP masks with closed loop systems, but there's a lot of debate as to which one is better. As far as what's actually shown benefit in the literature, it's the nasal cannula has the benefit in the past. That may change with the data that's coming out of this. So there's a lot more places now that initially planned to intubate early that did that and ended up with problems with ventilator allocation. And they've also shown that some people, by not putting them on a ventilator right away, were able to turn the corner or at least delay it some. So I think there's a bigger trend nationally towards non-invasive ventilation. And there probably is some aerosolization risk with it. So,
like, do we know what the mechanism is that's making their pulse ox drop? Like, is it lung thing, blood thing?
yeah,
Do we
so
know?
there's several things that are doing it. The biggest one probably is fluid. So they develop, fluid in the airways. And unlike things like really bad pneumonia in patients who've been on the ventilators where they get really terrible lung compliance, this looks like it's just, fluid and then atelectasis where the lung air sacs are collapsed. So then you have a lot of shunt occurring. So that high amount of blood that's, bypassing the lung, basically not getting oxygenated. There's also probably a lot of microvascular blood clots occurring in the lung, also in the kidneys and liver, that creates, a VQ mismatch. So then you have aerated portions of the lung that are not getting good blood flow. So it's the combination of these two kinds of VQ mismatches that are, leading to that, they think. They think that that's some of the reason that repositioning is helpful. If you keep repositioning the patient, you may, shift those relationships and get blood flow to different parts of the lungs. So
Why the blood clots?
So they think that there is a propensity towards coagulation in this illness. So this microvascular thrombosis and eventually DIC, the disseminated intervascular coagulation. Some places are doing a lot of trials with giving people blood thinners based on D-dimer levels. Again, that's all kind of experimental. We don't know the answer to that. So moving on. I guess subcutaneous epi is another option. And I would think about that more than I have in the past right now. If I have someone that I think is, got underlying COPD or asthma, they have some bronchospasm and I can't get nebulizer treatment. So that would be another option. If we have to use a BVM, make sure we're using a viral filter immediately after the mask. And we're trying to get a good seal on that. I'd be using a two-hand technique. So with two providers. So one provider operating the bag with the other doing double thumbs down. I would consider, excuse me, geez, my COVID is really flaring up right now. Hopefully not, but using a supraglottic airway with a viral filter early in codes, making sure that we're not continuing compressions during the airway placement. That would be a change from what we normally do. I put in lung protected ventilation. So if we are bagging someone, we want to think about using lower volumes. If we're milking all that air out of those bags, that's like 1,200 mils, and we really should be using, around 480 for the average adult male, and 360 for the average, or 380 for the average adult female, 360 for the average adult male. So it's lower volumes than we do. So we want to think about using that PEEP valve. I might actually consider turning that PEEP valve up in these patients.
So Mike, we're starting at 5 right now. Should we start higher or
I would probably start at 8.
Okay.
And I would not feel bad about going to 15 if I can't maintain SATs greater than 92%. This would be like in a post-ROSC situation. Transport, again, I want to really emphasize notifying the receiving facility early. I've got a lot of complaints that with like a couple critically ill or cardiac arrest patients that they didn't get notification early enough. And to be honest, I think some of that is also that people get that notification and they don't start thinking about the things they need to do at the emergency room soon enough too. So I have put that specifically out. So I think it's on all of us. It's not something that anyone is doing wrong.
Mike, can I pause? A question came in about MAG. Is there anything for respiratory distress? Any
I think
changes with
it'd
that?
be fine to
Okay.
use magnesium.
All right.
Again, be careful in really hypotensive patients, but that would be safe for magnesium. Family members, we don't want them riding in the transport vehicle. We want to try and isolate the driver from the passenger compartment as much as possible. These are things that we've been talking about for a while. We don't want to recirculate the air inside the ambulance. Cleaning of the vehicle, again, we want to make sure we're leaving those doors open. We're letting droplets settle out of the air. Probably the minimum is 10 minutes. We want to wear a gown and gloves when we're doing that, face shield and mask if we expect to have splashes, and use the appropriate disinfectants, which we're doing good on right now. So I'm trying to think if there's any other specific things I wanted to cover. I think the biggest things are reporting early to the hospital, and then the change in using N95s for known or suspected patients. So I guess we'd open it up for questions.
So has our status for initiating CPR changed at all since our last meeting?
Mike, did you hear that?
Yeah. So I think it's reasonable to not start CPR for unwitnessed by the caller PEA. So if you arrive there and the patient is in PEA, or sorry, unwitnessed asystole. I don't want to misspeak again. I'm sorry. So if you arrive there, the caller did not witness the arrest. They're in asystole. When you get there, you can consider terminating at that point. I think that's pretty reasonable. Otherwise, I think we just need to make some subtle changes to how we're doing this with early airway management, limiting the number of providers if possible, wearing the appropriate PPE.
Hey, Mike, just with the number of cases, I know we've kind of talked about this before. I feel like we're still good rolling with our pit crew CPR and give everybody a chance. I think it's where we're at right now, and with no, I mean, that'd be a big change for the system, just even what you just said there. So I feel like we're good here rolling like we are right now, unless things drastically change. I don't see a good reason to drop our patient care standard. What we're giving everybody a chance right now.
I don't think we, I mean, I think that we're not going to change too much, to be honest, by doing that. I mean, how many, cases are we really continuing CPR aggressively for asystole unwitnessed by the caller? That's going to be a pretty low number of cases. So.
Well, I mean, we're still giving them the chance with our 2 rounds of drugs and CPR and airway management and everything. Yeah. I just don't, to me personally, I don't feel like we're there right now to make that change to the CPR.
I don't know the answer to that for sure. I'm just nervous about the amount of exposure of providers and the amount of PPE required to continue to do that for some patients that are going to be, the patients that are not going to get benefit from it in a normal situation. So.
We're good on, I mean, I would like to table that one until we get a huge influx, and then we have a plan in place to limit that exposure if we get to that point. I just don't feel like we're there yet.
All right. Yeah, we can see, we can try and see how we do. So
we're just table that for now, but it is on everybody's radar.
Yeah. My threshold would be lower for sure in that situation. So,
Mike, what would you say to the guys like that run in a lot of transient calls? It seems like every one of them will say they have a fever or cough, which one's stress, all that stuff. As far as transporting to the hospital, can we discourage that strongly, or?
I think it's going to be difficult because those are going to be the patients that's going to be harder to, meet the non-transport criteria for the social reasons. I think if you did a good assessment and if we were able to contact the clinic there at the POV or something like that, that would be reasonable. But the chances of being able to refuse transport on those is going to be really low, I think. And make sure they put them in a surgical face mask, is the biggest thing. And we'll have to figure out a lot of those patients are going to be getting ruled out and ending up at the Bel Air. So.
Like, are we going to see changes with the opening of the state in our protocol?
What was that?
We're going to see changes with the opening of the state in our protocol. Do you anticipate any changes?
I think they're going to update the pandemic flu guideline because it's too specific is really what that's come down to. I was on the ECC call and we talked a lot about the COVID stuff statewide, but we really just continue to focus on, several EMS issues with, protocols and medical direction and, those issues. So I think I don't know right now. I haven't seen anything from the state that has been, super helpful for doing the stuff that we're doing right now, other than links to the guidelines that other places are using. I would say as far as what we're doing here, it's on par with what most places are doing nationally. So.
What other questions do folks have out there? We got Dr. Gilday on as well, and any other questions for folks, procedural or otherwise?
Hey Mike, this is Matt for Station 5. I was just wondering what you saw the benchmarks being or some sort of framework for kind of returning to business as usual, at least for the services that you provide medical direction to.
Yeah, as far as like returning to standard operations, I think that the unfortunate part about this is what we're going to see is these little spikes in cases. And if we get a huge spike locally, that would be, significant. But I don't think we're going to be changing a lot of the PPE stuff we're doing for a long time, conceivably through the fall or longer. So I don't know the answer to that right now. So I think we're still really doing most of our business as usual right now. We've changed a couple things as far as potentially staging fire to limit exposure, but most of the stuff we're doing is really similar to what we did before. Just taking some extra PPE precautions, modifying some of our respiratory care right now. So. I certainly wouldn't make any big changes till we see what, for a couple of weeks after relaxing social distancing to see what happens. Because I think we just don't know what's going to happen anywhere, but specifically locally with that. So.
Do you have any thoughts about, I think it's Sweden, so it feels like they didn't do much social distancing at all.
Kip, can you say that again a little louder?
Well, just about, Sweden, I just watched the news. They didn't do any social distancing at all. How they compares what they did, how the United States has been more, a lot of restraints and stuff.
Well, I think we started social distancing a little late, and it's certainly evident from the number of cases we have nationwide. And a lot of factors led to that, like how many people are traveling internationally, to and from the United States, especially through huge hubs like New York. So I think that's a big reason we had this. We also had specific things happen, like patients traveling to Washington, and then the nursing facility having community transmission occur there early. So I think all those things have kind of led to this happening. I haven't looked at Sweden specifically. I can't speak to that. So, but I imagine the amount of their population density is a little bit lower. There's a lot of geographic isolation there, and then there's probably not much travel through there. So.
Can I ask a question?
Mike, there's a question here.
Yeah.
Yeah, go ahead.
Hey, Mike, this is Jeff. This is more of a question for Gilday, just to say if we're going to be inconsistent here. Does the rule have any desire to change what they're doing from a CPR standpoint? I mean, the city's going to stay where they're at.
I think that where we're at is because of the caseload that we've had, we haven't had huge spikes in patients, and that we believe that a plan needs to be in place, that we need to start thinking about it. But as for actually initiating that plan yet, we're not there yet either. As well, I think it would probably be appropriate if there were some sort of age guidelines as well, when it comes down to just either limiting or not initiating care on specifically like asystole in a pediatric patient. That might be a little hard to sell.
Yeah, no,
Yeah,
sorry,
that's perfect. That's
I didn't have
perfect.
that in
Thank you.
there, but John and I talked specifically about that, and I would agree. I would, I don't know what that age cutoff would be for sure, but I might consider more aggressive resuscitation for, less than 55 or 55 and less. So.
Yeah, and I think that's good. I think that 55 and older, which I say that begrudgingly since I'm 56, but
56.
But I think that because of the mortality rates in those patient populations, that's more appropriate if you're really going to not provide care or limited care. And then 18 or younger, we could probably go down maybe a little bit on that age, but I think the pediatric population deserves a chance. But definitely over 55, I think needs to be a little bit more thought toward limiting care on those individuals if we get hit hard and really having to not question, but think harder about who we're giving care to and what our resources are.
I would add to, this is unrelated, is that we really should be encouraging people to seek emergency care if we need it. We've had several people complete strokes and MIs that have not come into the emergency room or come in delayed. And I think that we still need to be taking care of, things the way we normally do. But we just need to be, again, using the approach we have with wearing the appropriate PPE for the appropriate intervention. So.
Yeah, because that has been an interesting phenomenon that all of a sudden all these cases of MIs and strokes and other maladies have dropped off. It doesn't mean it's not happening. It's just that people are afraid to come to the ED many times and you don't see it. And it's like Mike says, and they, complete a stroke, get no treatment, or an MI, maybe they die. And it's really, we need to promote that coming in and not dissuade everybody.
That was Dr. Gilday from MRFD talking there, if you can't see.
Oh, sorry.
I will say that I would also start thinking a little bit about, it's been my perception that we're seeing a little bit more violent stuff as far as, people who are kind of out of control. We've had a number of those recently, and this guy, anyways, so those have been kind of difficult situations, and I think we could see more of that. Some of that's driven by substance abuse and mental health stuff, and then the additional stresses that are going on with this in the community. So I would be cautious of that. I think so much of the time we're really fortunate that we don't have to worry about that. But things like, potentially putting someone on an air medical platform that it could be a dangerous person, we should really make sure we're not doing stuff like that. So.
I have a question at Station 2. Can you hear me?
Yeah.
So I might have missed this. Is this showing any signs of being seasonal like the flu? I don't know if you covered that or not. Or is this going to go on like this all summer? Is it going to?
Yeah, so I don't know the answer to that. My thoughts are what we're going to see is these little sporadic groups of cases throughout the summer. Just because we don't, in Montana, we haven't had a ton of people exposed to this. So there's not a group of patients out there who have antibodies that are going to be less susceptible because of the social distancing things we've done. which has probably been more successful here again because of the geographic isolation of different communities. So
Don't you think, and this is obvious, but this state is tourism, and in 2 months, when it gets nice, everybody in the country is going to want to go to the lowest state, the lowest numbers. We have Glacier and Yellowstone, people coming through. I mean, there'll be millions of people coming here, don't you think? I mean, don't you think those spikes might be a little more significant than just a blip? If it does.
it is certainly my concern. And that's why I don't think we should, relax any of the protective measures we're doing. And I guess it just remains to be seen what happens nationwide. I heard one of the virologists talking about New York specifically, and they were estimating that even in New York, where they've had tons of cases, that they think that probably only 20% of New York has antibodies to this, which means that their surge might not have happened completely yet. So I do think we need to be really cautious about how we open things up, and I think things are going to be different for a long time because of that. So
Thank you.
So I guess I've heard it both ways, but do they know yet if you can get it again and then you showed that graph where it mutates a whole bunch?
Yeah.
What's the best thought on that right now?
Can people hear questions whether you can get it again?
So that's it. So now that we're getting more testing for serology, which is where they measure antibodies, I think that we're going to start seeing how likely that is. I'm sure it happens because even people who've had, coronavirus, other types of coronaviruses, they did an experiment where they gave them, an infection and they measured their antibodies and then they re-exposed them to the same thing later. And most of those people developed a recurrent infection actually a year later. And what was interesting though, is that the patients who'd had it before tended to have a attenuated version, so a less severe version of that illness, because they have probably some immunity. And I think that's likely that people who've had this before can get it again. And hopefully it's less severe.
So can I ask a part 2 question? So then thinking, what are their thoughts on like a vaccine with that in mind, that it will be like a seasonal, like a every year vaccine for that reason?
Yeah, so there are a couple issues with the vaccine. The first is that this is the small virus that mutates a lot, and it may be difficult to find a persistent target for that vaccine, meaning how the vaccine works is it generates our immune response to a specific part of the virus. But if that virus is changing enough, I don't know how. I'm not an expert on that, but I've heard that argument made. The flu, when you look at the flu vaccine, the flu is a much larger virus. It has a larger genome, but it rearranges frequently too. So, even where we know that whole flu gene, there's the H antigens and the N antigens that make up the flu virus. And even then, we're just kind of basing our best guess on what happens with the first flu cases, like in Australia, for what the flu vaccine looks like every year. So it may take quite a while to get a vaccine. So it will have possibly a similar process happen where we start seeing cases, we find out what those cases look like genetically, we adjust the vaccine to them, and then start vaccinating. And I don't think we're close to a vaccine. I mean, it's minimum of like next year, I think. So.
Yeah, it's Gilday. I agree with Mike. I mean, vaccines, everybody thinks we can throw together a vaccine in a year. That would be that'd be great if it could happen, but I'm not confident that will occur. And as for the antibody testing, we don't even know yet, like Mike was answering earlier, that just because you have antibodies that you actually, how much immunity that would give you for future infections and what that value is. They're not even there yet to know what that value is. That's it.
Mike's still here.
Yeah.
What other questions do people have out there? Any other issues we need to bring up? Anything else we should talk about as a group? Mike, anything else to add?
It's hard to stay vigilant when the prevalence locally is low, but it is important. And I think now that the supply chain hopefully is getting caught up, we'll be able to do a better job. So just encourage everyone to do that. Continue to recycle those masks, even if we're not getting them back to us. They're getting into the system, and it's going to be good. So we'll see what other kind of PPE conservation strategies come out of this too. So.
All right, thanks everybody. This has been recorded. I'll put it on Messi's YouTube channel there. Mike, Dr. Guild, everybody else, thanks for chiming in.